In this unit, we will be looking at various respiratory disorders. Before we look at the actual disorders, we need to look at some of the more common signs and symptoms of respiratory disease. The first of these is a cough. A cough is a reflex response in an attempt to try and clear the lower respiratory passages. It is often seen with lung disease where mucus or other fluids accumulate in the lower airways. What could cause a cough or causes fluid to accumulate might be inflammation, could be increased mucus secretion due to irritation such as irritants or a tumor, or it could be the result of an increase in blood pressure in the pulmonary capillaries leading to the accumulation of fluids. This would be known as pulmonary edema. A productive cough is one that raises fluid, also called sputum, so that it may be cleared. Hemoptysis refers to the production of a bloody sputum. A purulent sputum is an indication of an infection. A non-productive, dry, hacking cough is one that does not produce sputum. Dyspnea is another common sign or symptom of respiratory disorders. Dyspnea is a shortness of breath. This occurs when one experiences a greater respiratory effort at a given level of physical activity. Dyspnea is often due to either airway obstruction or due to lung disease that causes stiffness of the pulmonary tissues, leading to a decrease in compliance. Compliance refers to the ability of the lung tissues to expand in response to a given inspiratory pressure. The last common sign or symptom of respiratory disorders is cyanosis. This occurs when blood contains large amounts of unoxygenated hemoglobin. As a result, it takes on a dark red, almost maroon color that results in a bluish tinge to the skin. Cyanosis may be due to peripheral vasoconstriction. This would cause a decreased blood flow to the periphery, resulting in peripheral cyanosis. It could also be due to central cyanosis. This is inadequate blood oxygenation. Central cyanosis could be the result of an abnormality in the respiratory membrane, or it could be due to a mismatch between airflow and blood flow. This is known as the VQ ratio. V for ventilation, Q for perfusion. If the VQ ratio is high, this means that there is an increase in ventilation, but the blood flow through the pulmonary circuit is decreased. This can lead to cyanosis. If the VQ ratio is lower than normal, this means that there is decreased ventilation, but the blood flow to the lungs is fine. This, however, can also lead to cyanosis. These differences in VQ ratios are illustrated in this picture. The top picture represents a normal ventilation to perfusion ratio. In B, there is an increase in ventilation, but notice that the blood flow going to the alveoli is much lower than normal. This would cause a decreased VQ ratio, which could lead to cyanosis. Here, ventilation is decreased, but the blood flow through the alveoli is normal. This would cause a decreased VQ ratio, also leading to cyanosis. The normal functioning of the lungs can be assessed through various pulmonary function tests. The first is spirometry. This assesses the airflow versus time, usually in a forced exhalation from maximally inflated lungs. This graph illustrates different volumes that could be determined by using the technique of spirometry. One common technique that is utilized is something called a forced expiratory volume in 1 second. First, they would measure a person's vital capacity. Then they would have the person inhale their vital capacity, then try to exhale it as fast as they could. They would then measure the percent of the vital capacity that was exhaled in the first 1 second of exhalation. This is known as the forced expiratory volume in 1 second. If this number is lower than normal, this is often an indicator of an obstructive pulmonary disorder. One can also perform various diffusion tests looking at diffusion capacity. This looks at the status of the respiratory membrane through the uptake of carbon monoxide. This can be used to diagnose various interstitial forms of fibrosis. One can look at arterial blood gases. This looks at the levels of oxygenated hemoglobin as well as the pH of the blood. Lung elasticity can be measured. This gives an indication of compliance. This will look at the lungs' ability to expand and recoil normally. Finally, there are various lung volume tests that look at the ability to ventilate the pulmonary airways normally. Here you would be looking for indications of either obstructive or restrictive diseases by measuring both the reserve or residual volume as well as the total lung capacity. Now we will look at different types of respiratory disorders. The first grouping of disorders are the result of hypo-perfusion. This means that there is decreased perfusion through the pulmonary capillaries. In other words, there is a decreased blood volume in the pulmonary capillaries. This can be due to one of three different conditions. It could be the result of left heart failure, it could be the result of thromboembolisms, or it could be the result of hypoventilation. Remember, with the heart and the lung, the relationship between the heart and the lung, the pulmonary vessels are going to empty into the left side of the heart. So anytime the left side of the heart fails, this is going to cause blood to back up into the lungs. As blood backs up into the lungs, new blood is trying to enter the lungs from the right side of the heart. So this is then ultimately, over time, could result in problems with the right side of the heart as well. First, we will look at left-sided heart failure as a cause of hypoperfusion. Left-sided heart failure leads to pulmonary congestion and hypertension. As the left side of the heart fails, this will result in an increase in pressure in the lung vessels. This will lead to an increased resistance to the right heart's ability to pump. Over time, this will cause a decrease in pulmonary flow. New blood cannot enter the congested lung vessels from the right side of the heart. With chronic hypertension, this can lead to pulmonary arterial sclerosis. This can lead to stenosis and a decrease in vascular elasticity. Stenosis will also increase the pulmonary blood pressure. This will further increase hypertension. This can lead to progressive deterioration, causing cor pulmonale. Cor pulmonale refers to hypertension in the lung as well as hypertrophy of the right ventricle. If it is severe, it can lead to vascular wall necrosis and pulmonary hemorrhaging. Second cause are thromboembolisms. These usually arise from deep veins in either the calf or the thigh. The degree of pulmonary blockage will be determined by their size and their numbers. Usually, thromboemboli are accompanied by pulmonary hypertension. There are two mechanisms involved with the development of pulmonary hypertension. First, the blocked vessel will cause an increased pressure upstream from the occlusion. And secondly, platelets will begin to release vasoconstrictors. These platelets become activated when they adhere to the emboli. You will also see an increase in the VQ ratio, various degrees of dyspnea, tachypnea, which is an increased respiratory rate, and a decrease in the concentration of oxygen. Infarctions in this condition are rare due to the numerous links between the pulmonary arteries and the bronchial arteries. However, if an embolism is very large and ends up occluding the pulmonary trunk, you will see a severe decrease in blood flow to the lungs, resulting in a very severe drop in oxygen delivery to the tissues, and this can result in death. The third condition is reduced ventilation. Here you will see reflex vasoconstriction response by the pulmonary arterioles. This would be fine under normal conditions. However, if it's chronic, it can produce pulmonary hypertension, which can lead to an increased load on the right heart, resulting in pulmonary hyperperfusion. The next group of respiratory disorders include things that result in hypoventilation. This is a reduced airflow. Here you would have a normal blood flow delivered to underventilated alveoli. As a result, carbon dioxide cannot be cleared as well, and not enough oxygen will be able to enter. This could be due to one of two different factors. It could be due to something that will restrict the ability of the lungs to expand, or it may be due to obstruction of the airways. We are first going to look at various examples of obstructive lung disorders, but first we need to revisit the function of a cough. Cough is a very important clearing mechanism for the lungs. It acts to clear excess secretion, and it also allows our body's defenses to take care of the damaging agent. When one loses this clearing function, it may allow bacteria to become established, resulting in acute bronchitis. It also can produce hypoventilation due to a decreased ability to expire. This can result in smaller FEV1 ratios. The first example of an obstructive lung disorder is chronic bronchitis. This is a very common obstructive disease that is diagnosed based on 2 years where a productive cough is present for at least 3 months in each of those years. The most common etiology of chronic bronchitis is long-term inhalation of irritants. These include cigarette smoke, sulfur dioxide, and nitrogen dioxide. These last two irritants are common components of air pollution. The pathogenesis is typically due to the mucous membrane's response to these long-term irritants. This includes inflammatory hyperemia and exudate formation, as well as hypertrophy and hyperplasia of the mucus glands. Together, these first two will lead to thickening of the mucosa. You will also see the development of a chronic cough. This is an attempt to clear this thick mucus. You also see metaplasia of the bronchial epithelial tissue. They will lose their cilia. They will go from being ciliated columnar epithelial tissue to stratified squamous epithelial tissue. Due to the heavy mucus and the loss of cilia, this will cause the small airways to be plugged, and it will also isolate microorganisms. This picture illustrates the change in the lining of the normal mucous membrane. Here you can see the columnar epithelial tissue with cilia, and this would be a normal amount of mucus production. In chronic bronchitis, you see hyperplasia of the mucus glands producing large amounts of this thick mucus. Also, the epithelial tissue has changed. They have lost their cilia, and now they are stratified squamous. Over time, you will see an increased susceptibility to respiratory infections, again due to the thick mucus and the inability to clear the mucus or bacteria due to the loss of cilia. If it's advanced, hypoventilation will cause hypoxemia and hypercapnia, which is an excess of CO2. This will lead to a vasoconstriction reflex, causing an increase in pulmonary pressure and ultimately an increase in right heart workload. The hypoxemia will also lead to an increase in erythropoietin secretion by the kidney. Remember, erythropoietin is a hormone that stimulates the production of red blood cells. This will cause an increase in blood viscosity, putting even more load on the heart. This shows the pathogenesis. Again, you have chronic irritation that is going to cause a change to the epithelial lining, causing them to lose their cilia, making it more difficult to clear microorganisms, leading to an increase in infection. This irritation can cause mucosal swelling, narrowing the lumen, and this is where the obstruction comes in, leading to dyspnea. Also, you see an increased glandularity, causing an increase in mucus production, and this is what causes the productive cough. Symptoms of chronic bronchitis include a productive cough, increased respiratory infections, right heart failure, episodic hemoptysis, an increased hematocrit, pulmonary hypertension, increased airway resistance, and an increased residual volume. Our second example of an obstructive lung disorder is pulmonary emphysema. Here you see abnormal enlargement of the airways beyond the level of the terminal bronchioles. You will also see destruction of the alveolar septa, causing adjacent airways to merge with each other, forming an even more enlarged sacs. The term bulla refers to air spaces that are greater than 1 centimeter in diameter. Emphysema can be classified in one of 3 different ways. It is called centrilobular if it involves only the proximal respiratory bronchioles. Paraseptal emphysema involves enlargement in the distal sacs, and panlobular involves enlargement that is distributed over both the proximal and the distal airways. These classifications can only be determined either with surgical removal or at the time of autopsy. They cannot be determined clinically. The effects of emphysema include the effects when small airways collapse during exhalation. This causes destruction of the alveolar wall and they lose support. This will then obstruct the outward flow of air. Another effect is a decrease in elasticity. This causes less expiratory drive so that one needs extra effort in order to exhale. Symptoms of pulmonary emphysema include dyspnea, lung hyperinflation, exercise intolerance, expiratory wheezing, a higher residual volume, higher airway resistance, and a lower compliance. One etiology of emphysema is the normal aging process. From middle adulthood onward, we lose approximately 0.5% of our alveolar surface area per year. The good thing is that this results in little functional loss. The most common etiology of emphysema is smoking. After about 10 to 20 years, some smokers will begin to show signs of a decreased FEV1 ratio. They are then the ones that are most sensitive to not only this destructive process, but put aging on top of that, and then they are more likely to develop emphysema. Now, what does the smoke do? Main thing it does is deposit particles in the lungs. Once these particles are deposited, they cause the macrophages to release materials that are chemotactic for the neutrophils. These materials also stimulate an enzyme called elastase that ends up breaking down elastin. Smoke inhibits material in the plasma that would normally counter the effects of elastase. And also smoke interferes with the synthesis of new elastic fibers, so it impedes the repair process. And this is showing the pathogenesis of emphysema. Smoking causes particles to be deposited in the airways, which cause an inflammatory response, bringing in the neutrophils that end up releasing and stimulating the effect of elastase that destroys the elastic tissue in the septa of the alveoli. Smoking also interferes with the material that prevents elastase from causing this damage. This picture shows the difference between the alveoli in a normal lung and the alveoli in emphysema. Notice these large bulla, these large spaces in the lungs. The next type of obstructive disorder is small airway disease. Here, damage is to the small non-respiratory bronchioles. You will see lumen reduction due to either fibrosis in the walls of the airway, or it could be due to bronchial constriction response to the inflammatory mediators, or it could be the result of dilution of surfactant by the exudate. You do not see any significant decrease in the FEV1 ratio, but this disease can be picked up by special pulmonary function tests. This is a common disorder that occurs when one breathes secondhand smoke. The next disorder is chronic airway obstruction. Here we typically see signs of both chronic bronchitis and emphysema, as well as some small airway involvement. There are many other terms that are also used to describe it. COLD, COPD, which is probably the most common one, and CAL. Here, there are many overlapping conditions that result in the respiratory difficulties. Signs and symptoms include dyspnea, exercise intolerance, a long-term productive cough. If one is delayed in getting medical attention, it can lead to severe dyspnea and irreversible lung damage that results in respiratory insufficiency. You will also see signs and symptoms of both chronic bronchitis and emphysema. Which one of these present themselves depends on the degree of involvement of either one. One of these may be dominant, or they may both show equally. Many times the patients are referred to as respiratory cripples due to their lack of tolerance for any exertion. Therapy. If the damage has become irreversible, all you can do is try to prevent further damage and to cope with the effects. First thing to do would be to stop smoking. This will prevent further damage as well as help the cough. Oxygen therapy can be used to help the hypoxemia. One can also use bronchodilators, corticosteroids, and antibiotics. Diuretics and vasodilators are often used when right heart failure begins to develop. The next type of obstructive lung disease is bronchial asthma. This is acute episodes of bronchial obstruction. Oftentimes it is seen as a part of CAO as well as bronchitis. The big difference, though, is that bronchial asthma is reversible. This is not true for either chronic bronchitis or for emphysema. Characteristics of bronchial asthma: you will see bronchiolar constriction, mucus hypersecretion, and inflammatory swelling. All three of these will lead to dyspnea, severe cough, and wheezing upon exhaling. There are different types of bronchial asthma. The first is referred to as extrinsic asthma. This accounts for about 10% of all bronchial asthma. Extrinsic asthma tends to develop in children, and they feel there may be a genetic link involved. This occurs due to the production of IgE antibodies that are made in response to inhaled allergens. These are airborne particles, some of the more common ones being pollen, dust, and animal dander. When the person is first exposed to these allergens, they will become sensitized. What this means is that they begin to make IgE antibodies to these allergens. Once made, these IgE antibodies will bind to the surface of mast cells, as well as the airway mucosal surfaces and basophils. This makes a person now sensitive to the allergen. When they are exposed again, these allergens will bind to the antibodies on the surface of the mast cell. This will cause the mast cell to respond, and they are said to degranulate. What this means is that they release various chemicals that end up causing the symptoms of asthma. Some typical chemicals that are released by the mast cells are histamine, leukotrienes, bradykinins, thromboxane, and platelet activating factor. The resulting symptoms include bronchospasms, an increased mucus production, and an increased permeability of the capillaries. Another type of asthma is intrinsic asthma. This tends to hit adults with no history of allergies. The symptoms here are due to autonomic stimulation of the airways, resulting in an increased parasympathetic response. The symptoms are the same as extrinsic asthma, including smooth muscle constriction, increased mucus production, and an increased permeability of the capillaries. Here, irritants make contact with the mucosal surface and activate receptors that lead to these above symptoms. The irritants, what can cause intrinsic asthma, could be air pollutants, chemicals, dust, drugs, and even physical exertion. This is showing the pathogenesis. This is the extrinsic pathway, where you inhale an allergen and they bind to IgE antibodies on the mast cell, causing them to degranulate and release chemicals, which result in the basic symptoms. Extrinsic asthma could be due to inhaled irritants, infection, or exertion. again causing an increased parasympathetic response that causes the same symptoms. Another type of asthma is mixed asthma. This is airway narrowing due to an overlap of both allergic and autonomic mechanisms. For example, the mast cell products could stimulate epithelial receptors, or the irritants might damage the epithelium, leading to an attack, and thus allowing access to the mucosa where they can induce IgE formation. Therapy: first, one should try to eliminate exposure to the allergen or to the inhaled stimulant. Use bronchodilators and other agents that will act against the autonomic vasoconstriction response. Antibiotics can be used when infection is also involved. And sedatives may be used when emotional upset is what is leading to the attack. One last type of asthma is status asthmaticus. This is a severe attack that does not respond to therapy. The compromised ventilation here can lead to cyanosis, and it can be fatal. Our last example of an obstructive lung disease is cystic fibrosis. This is a systemic condition involving defective exocrine secretions. This results in electrolyte imbalances that occur in the electrolyte imbalances that result here will cause the production of thicker secretions from many organs, especially the lungs. This viscous mucus then obstructs the airways. Cystic fibrosis is a genetic disorder. Symptoms associated with cystic fibrosis: it will become very difficult for them to clear the passages of this thick mucus. As a result, you will see reduced ventilation that can result also in an increase in respiratory infections. You can also see repeated bouts of bronchitis and bronchopneumonia. These will cause damage leading to fibrosis. The fibrosis will cause even further loss of respiratory function, as well as pulmonary hypertension and cor pulmonale. There is no cure for cystic fibrosis. Death typically occurs before the age of 30 due to respiratory failure. The next grouping of disorders that result in hypoventilation are termed restrictive lung diseases. Here, there is restricted expansion of the lungs that cause a decrease in total lung capacity. This could be due either to a problem with the lung tissue itself, which would be known as an intrinsic condition, or it could be due to other factors that limit expansion. These are known as extrinsic conditions. First, we will look at extrinsic restriction. This might be due to a defective thoracic framework. Here, alterations are present in the thoracic skeleton that interfere with the normal lung expansion. This may include kyphosis, which is a rounding of the shoulders, scoliosis, which is a lateral curvature of the spine, kyphoscoliosis. Here the column is bent and rotated laterally. Or it could be the result of trauma that has caused damage to the thoracic cage. An example of this would be rib fractures that result in a portion of the thoracic wall becoming detached. This can result in decreased expansion and a decrease in ventilation. Extrinsic restriction might also be due to respiratory muscle weakness. This usually is the result of a type of muscular dystrophy. The weakened muscles do not allow sufficient chest expansion. Extrinsic restriction may also be due to either neural and neuromuscular defects. There are 3 factors involved here. It could be the result of a faulty output from the respiratory center. It could be a defect in the pathway from the brainstem to the respiratory muscles, or it may be a defect in the neuromuscular junction. We will look at each of these. First, damage to the brainstem or the central nervous system depression can lead to an inadequate stimulus to the respiratory muscles. What could cause this? Might be a brainstem injury. Could be increased compression from increased intracranial pressure due to either trauma or surgery. It could be a drug overdose or excessive anesthesia, or it could be the result of epileptic seizures. The second defect could be a neural pathway defect. These are typically seen in various disease conditions, the first of which is poliomyelitis. Poliomyelitis is due to a virus that ends up damaging the motor nerves that supply the respiratory muscles. Another disorder is Lou Gehrig's disease. This affects the motor nerves, and respiratory failure tends to develop during the later stages. Lastly, Guillain-Barré syndrome. Here you see demyelinization of the motor nerves that lead to faulty conduction. The last defect are neuromuscular junction defects. This is the junction between the respiratory motor neurons and the respiratory muscles they innervate. This can be seen with botulism. The botulinum toxin blocks the release of acetylcholine from the motor nerve endings. This will cause paralysis of the respiratory muscles. This is also seen in myasthenia gravis. Here, the acetylcholine receptors are damaged due to an autoimmune mechanism. The last cause of extrinsic restriction could be due to an increased resistance to expansion. This could be due to excessive accumulation of fat in the thoracic wall, commonly seen in obesity. This increase in fat may also interfere with the depression of the diaphragm. This is showing the various causes of extrinsic restrictive lung diseases. You have a congenital malformation or trauma that will compromise the thoracic frame, muscular dystrophy leading to muscular weakness, central nervous system depression, nerve diseases or neuromuscular junction disorders compromising the neuromuscular function, or obesity causing an increase in resistance. The other type of restriction is intrinsic restriction. In general, these are all called interstitial lung diseases. They involve the supporting connective tissue framework of the lung that provide elasticity. The elasticity of the interstitium plays a role in the lung's ability to recoil after inhalation. The effects of intrinsic restriction: you see stiffening of the lungs and reduced compliance, so it becomes more difficult for the person to inhale. This decrease in compliance will lead to a decrease in total lung capacity and an increased recoil of the interstitium. Another effect would be dyspnea and a decrease in tidal volume. You will also see tachypnea, which is rapid and shallow breathing. This actually represents a compensation mechanism. It is typically seen during exertion and can produce hyperventilation. Hyperventilation is also an effect due to the above three conditions, or the above three effects that we just discussed, and due to a increase in the recoil. And lastly, you can see a cough. Typically here, though, the cough is non-productive. This could be due to interstitial changes that affect the airway irritant receptors. There are two main types of intrinsic restriction. They include ARDS, which is Adult Respiratory Distress Syndrome, or CIRLD, which is Chronic Intrinsic Restrictive Lung Disease. We will look at ARDS first, which is edema of the pulmonary interstitium. The mechanisms by which this can occur: it can arise secondary to left heart failure. As we discussed earlier, this will lead to congestion in the pulmonary vessels, causing pulmonary hypertension. The hypertension forces fluid from the pulmonary capillaries into the surrounding tissues. This fluid will thicken and stiffen the pulmonary interstitium. This will then lead to a decrease in compliance and restricts the ability of the lungs to expand. This is known as cardiogenic pulmonary edema. Another mechanism is through damage to the pulmonary capillaries, resulting in an increase in their permeability. Water, electrolytes, and proteins, possibly even red blood cells if it's severe, can now leave the blood vessels and enter into the tissues. This will result in a decreased compliance. As the pressure increases, the exudate will be forced from the tissues and actually into the alveoli themselves. This will further compromise respiratory function. The onset typically follows some sort of injurious event. It may take several hours or even days to become apparent. Then one will begin to see tachypnea, dyspnea, and cyanosis, followed by complete respiratory failure. This typically is fatal in over 50% of the cases. Pathogenesis of this disorder. Intrinsic restriction will develop due to non-distensible fluid in the interstitial space. This will cause a decrease in compliance. The exudate that's produced also dilutes the surfactant, which also causes a decrease in compliance due to an increase in surface tension. This increase in fluid makes diffusion of oxygen into the blood very difficult. As fluid accumulates in the alveoli, this causes a loss of respiratory surface area and a decreased airway volume, ultimately resulting in a decrease in the VQ ratio, causing shunting and cyanosis. When the protein in this exudate is exposed to air, it will begin to denature. This will form a layer of hyaline membrane on the alveoli. If the disorder is not fatal, it can lead to fibrosis in the interstitium, resulting in chronic loss of compliance. This shows the pathogenesis. There's some type of lung damage. It can lead to increased capillary permeability, causing fluid in the interstitium, resulting in stiffness. This fluid can also dilute the surfactant, leading to dyspnea. When exposed to air, it creates the hyaline membrane, making gas exchange very difficult to occur. And it can also lead to fibrosis, causing a reduction in compliance. What are some of these initial injuries that can result in ARDS? Could be trauma, exposure to biological toxins, inhaled irritants, circulatory shock, also known as shock lung, central nervous system injury causing vasoconstriction and increased pulmonary blood pressure, pneumonia, which causes acute inflammation of the lung parenchyma. Pneumonia typically follows viral pneumonia, but it doesn't have to. It could also be associated with with aspiration pneumonia, which occurs when one aspirates vomit while unconscious. Another initial injury could be DIC. This would result in an increased permeability of the capillaries. Initial injury could be a near drowning experience. This would cause damage due to osmotic water movement. Could be due to damage to the pulmonary capillary endothelium as the result of exposure to toxins or irritants. This occurs, for example, when one inhales smoke from fires. Blood-borne irritants could be present due to enzymes from the pancreas or from pulmonary enzymes that are produced in an attempt to break down fat emboli. Extra fluid volume in the blood could also cause this. This extra fluid could be the result of a failing left heart, or it could be due to the administration of IV fluids which overload the pulmonary vasculature. Both of these would be known as would cause pulmonary hypertension. Again, this is showing the pathogenesis. Burns or heart failure can cause circulatory shock. You can have lung infections. Enzymes produced from either the pancreas or fat emboli producing blood-borne irritants, inhaled irritants, or trauma and fluid overload that causes pulmonary hypertension. Treatment: you need oxygen inhalation to relieve the hypoxia, mechanical ventilator to help increase airflow, and the use of diuretics to help to decrease the fluids in the lungs. The second disorder is CIRLD. This involves long-term changes in the pulmonary interstitium. Stiffness will develop over a long period following the initial damage. Chemical mediators will be released that will also promote a fibrogenic response. Eventually, collagen will be deposited at the expense of normal elastic tissue, and this is what causes the decrease in compliance. The most common cause is low-level occupational exposure to an irritant over a long period of time. These irritants would include gases, drugs, dust, or any infectious agent. The levels are low enough that they are not bothersome, so the person keeps working. several months to years are needed before clinical symptoms begin to show. Some of the categories of CIRLD include pneumoconiosis. This is caused by the inhalation of irritant dust or droplets. For example, this is what occurs in minors. The levels of dust eventually overwhelm the airway particle clearance defense mechanisms, and the particles will begin to accumulate in the interstitium. These are typically described based on the inhaled particle. For example, it could be called silicosis if the particle is silicone, or asbestosis if it is asbestos. The way it develops, early on, fibrosis will begin to develop at the point of particle deposition. This will cause the development of nodules of fibrous tissue. In asbestosis, these nodules tend to be very diffuse. Then, progressive massive fibrosis can occur as these nodules begin to enlarge. You can also see granulomatomatous inflammation in the lungs. This is the formation of granulomas. This usually occurs as the result of an inhaled metal. As far as symptoms, this disorder will be asymptomatic for many years. Then one will begin to notice dyspnea, which gets progressively worse as the compliance decreases. One will have a cough. This could be either a productive or a non-productive cough. And you see an increased risk of respiratory infections. Another category of CIRLD is due to infection. Here, fibrosis occurs due to the presence of an infectious agent, its products, or the products of tissue damage. Common etiologies include bacteria, viruses, or fungi. The organisms cause chronic inflammatory response that may involve diffuse or granulomatomatous pattern of cell infiltration, as well as fibrosis. Then there are various miscellaneous categories of CIRLD. This includes when inhaled agents cause an allergic response in the lungs. You will see cellular infiltration with granuloma formation followed by diffuse fibrosis. Could also be due to therapeutic agents such as radiation and anti-tumor drugs. There is idiopathic pulmonary fibrosis. Here you see immune complex deposition, but the antigen is unknown. This is common in males between the ages of 30 and 50. Finally, there's Goodpasture syndrome. Here there's an autoimmune defect that causes antibody formation against both lung and kidney basement membrane. This will cause interstitial hemorrhaging as well as various degrees of fibrosis. Therapy. CIRLD is non-reversible, so the therapy is limited. One thing you can do is stop exposure to the irritant, and you can also use steroidal anti-inflammatory agents such as prednisone. Something else that can result in hypoventilation are lung infections. These are more common in the elderly whose defenses are lower, as well as those who are immunosuppressed. Bacteria and viruses are the two most common causes. Bacteria will cause an acute inflammatory response. Exudate formation will be centered in the alveoli. Bacteria can also cause consolidation. This is infiltration by the inflammatory cells result in solidification in the lungs. With viruses, you will see inflammatory cells typically in the interstitium. Regardless of the cause, both are referred to as pneumonia. Next is respiratory failure. This is due to an inability to oxygenate the blood and clear carbon dioxide. Typically, you would see dyspnea and central nervous system symptoms such as memory loss, visual impairment, drowsiness, and headaches. The central nervous system signs occur because the nerves are very sensitive to a decrease in oxygen. First type of respiratory failure is known as hypoxic respiratory failure. This occurs when the concentration of oxygen decreases to 60 millimeters of mercury or below. This is often seen with chronic bronchitis and emphysema. Could also be seen with consolidation due to bacterial infections, with lung collapse, and with pulmonary hypertension. Symptoms include headache and nervous agitation. These first two are initially seen due to the hypoxemia. You can also see a decrease in mental activity, widespread tissue damage, and a loss of consciousness. These occur with a progressive decrease in the concentration of oxygen. Circulatory shock can develop with hypoxia to the brainstem, and hypoxic renal damage can also occur. Another type of respiratory failure is hypoxic hypercapnic respiratory failure. This occurs when the concentrations of carbon dioxide increase above 45 millimeters of mercury. This could be due either to any type of obstructive condition, or it could be due to hypoventilation, resulting from either central nervous system, thoracic cage, or neuromuscular abnormalities. Usually compensation mechanisms will kick in, which include an increase in heart rate and vasodilation. These will result in the production of warm, moist skin. You will also see muscular tremors, drowsiness, and coma. These are all due to the effects on the central nervous system. And finally, you can see acidosis due to the hypercapnia. This is showing the two types, hyper-perfusion, hyperventilation, which can lead to hypoxia and all of the symptoms related to low oxygen, and hypercapnia and all of the symptoms resulting from high carbon dioxide levels. Last, we will look at various miscellaneous pulmonary conditions, the first of which is atelectasis. This is a collapse of a portion of the lung. It is often associated with bronchial obstruction. With airway blockage over a period of time, air from the alveolar sacs will be absorbed into the blood. The presence of an obstruction will prevent new air from entering, and as a result, the area collapses. If the area is small, this tends to be asymptomatic. However, if it's large, then the perfusing blood will get less oxygen and hold on to the CO2. This can be seen with any type of an obstructive disease. It can be seen with aspiration of a foreign body. It can be seen with tumor growth that compresses the airway from the outside, and it can also be seen post-surgically. Anesthesia tends to cause obstruction through the increased mucus secretion. It can also be seen associated with ARDS due to the increased surface tension that is seen here will cause collapse of the small airways. Another condition is bronchiectasis. Here, medium to small size bronchi are abnormally dilated due to damage to the muscles and connective tissues in their walls. The cause could be congenital, or it could be secondary to necrosis associated with either bronchial inflammation or pneumonia. You will see respiratory epithelium here replaced with stratified squamous epithelial tissue. In bronchiectasis, it becomes very difficult to clear the secretions. This can lead to a cough. It can lead to further infections, a purulent sputum, and further bronchial damage. Hemoptysis can be seen due to the damage that's associated with very severe coughing. This is showing a comparison between a normal bronchus and a bronchi typical of bronchiectasis. Next is pneumothorax. This is when atmospheric air enters the pleural space and causes collapse of the lung. The presence of air will remove the normal pressure gradient that provides for expansion of the lungs against the thoracic wall. As a result, elastic recoil of the lungs draws them into a collapsed state. A pneumothorax may be due to trauma, such as a broken rib, a knife wound, or surgery. It could result accidentally due to medical procedures, for example, the aspiration of fluids. It can be associated with emphysema, it can be associated with tumor invasion, and one can also develop a spontaneous pneumothorax. This is common in males between the ages of 20 and 40 with no predisposing condition. Regardless, the defect that allows the air to enter the pleural space usually closes when the lung collapses. Once this heals, the lung typically will be able to expand again. Next is pleurisy, which is inflammation of the pleura, which are the membranes that surround the lungs. It is usually the result of some other abnormality, such as an infection of the lung parenchyma, thoracic trauma, or an invading tumor. Pleurisy is usually you will see significant exudate accumulate between the pleura. This is known as pleural effusion. This produces pressure on the lung tissue, causing a compression atelectasis. Dyspnea occurs due to the restricted movement, and one will also experience pain and coughing. You can draw off some of this fluid for examination. If pus is present, it is known as pleural emphysema. If blood is present, it is known as a hemothorax. Lastly is respiratory disease of the newborn, also known as respiratory distress syndrome. This is seen in premature infants or babies born full term to diabetic mothers. Dyspnea will occur shortly after they start to breathe. This is due to lack of sufficient surfactant. Not enough surfactant will cause an increased surface tension, and this increased surface tension results in a greater effort needed to inspire. This is what causes the dyspnea as well as chronic fatigue. It will also cause the collapse of terminal airways when the terminal alveolar air pressure is exceeded. Eventually, this will result in atelectasis. The lining of the alveolar surfaces in this disease become covered with a hyaline membrane. Remember, this is a protein-rich fluid type membrane. This causes a slow diffusion of gases. This slow diffusion, combined with a decreased surface area due to the atelectasis, will result in hypoxemia and hypercapnia. Death will occur very quickly without oxygen administration and ventilation.